I'd like to welcome Dr. Samir Parikh, our speaker for this evening. And the topic today is quite the crowd puller, it seems, and it's something that our knowledge actually keeps evolving on time and again. So my name is Dr. Omar Swali. I'm the consultant physician and nephrologist working for Sri Hindu Mandal Hospital in Dar es Salaam, Tanzania. And I'd like to welcome all of you to series 65. And boy, how we have aged in this webinar series. Uh, Dr. Samir V Parikh, who is going to be speaking to us tonight on lupus nephritis, an update. He's an associate professor of medicine in the Division of Nephrology at Ohio State University. Dr. Parikh has received his medical degree from the University of Cincinnati College of Medicine and has completed his residency and nephrology fellowship at Ohio State. He joined the Ohio State University faculty in 2011. He specializes in glomerular diseases with a special focus in the management of lupus nephritis, TMA, and monoclonal gammopathy. He is experienced in hypertension, general nephrology, acute renal failure, and chronic kidney disease management. Dr. Parikh's research has focused on uncovering novel biomarkers of disease and optimizing the use of kidney biopsy to inform management decisions in lupus nephritis. He has authored several manuscripts on these topics and has been the principal investigator on many trials of novel therapeutics for lupus nephritis and other glomerular diseases. And specifically, he was the site principal investigator for Aurinia Phase 1 and 2 lupus nephritis studies and co-investigator on the BLISS lupus nephritis study. So, Dr. Parikh, with that, we wish you a very warm welcome, and please take it away. Thank you so much.
Thank you for that.
One addition is Dr. Parikh, he authored the co-curriculum on the lupus update in 2020, and that's a great article that I think one must not miss the co-curriculum. Thank you very much.
Thank you for that kind introduction and that comment. Very happy to be here with you guys today and to be able to speak on a topic that I very much enjoy, and that's lupus nephritis. Can you guys all see my screen right now? I'll put it in presentation mode.
Yes, very visible.
Yeah. Okay. Good. Okay. All right. So today we have about an hour, and so I want to take this time and provide an update on lupus nephritis. You can kind of see my disclosures here. Research funding through the NIH, Aurinia Pharmaceuticals, Serrano, and Mallinckrodt in the past, and then consultancies across the board with a pharma that participate in lupus nephritis research. That includes Aurinia, GlaxoSmithKline, Bristol Myers Squibb, Kezar Life Sciences, and Alexion Pharmaceuticals. What I would like to do today is really focus and review the current approach to lupus nephritis diagnosis and management. A lot of that may be review for this group, but then evaluate the efficacy and safety profile of recently approved treatments for lupus nephritis. I mean, for the first time ever, really, we've had approved therapies for lupus nephritis. We want to explore how we can use these new therapies in clinical practice, and then briefly discuss the role of repeat kidney biopsy in the treatment course of LN. And so we hope to get through this in the next hour. And if you guys have any questions, by all means, feel free to stop me or put it in the chat, and I'll try to answer as many as I possibly can. I will be discussing some unpublished data or unapproved therapies as well, but we will put it in light of globally how we're looking at LN therapy. So let's start by defining the scope of lupus nephritis. So as we all know, lupus nephritis is common. It's one of the most common and severe manifestations of systemic lupus erythematosus. Overt lupus nephritis occurs in approximately 50% of adults and more in children. Close to 80% of children with lupus will develop lupus nephritis. LN is severe. It still results in end-stage kidney failure in 10 to 30% of patients within 15 years of diagnosis, and carries a 5 to 25% mortality rate in patients who develop proliferative LN at 5 years after diagnosis. And importantly, it occurs early. So oftentimes, and in greater than 50% of cases, lupus nephritis will present within the first year of SLE diagnosis, and occurs in greater than 80% of cases will occur within 5 years of SLE diagnosis. But the incidence and prevalence is influenced by many factors, including age, gender, race, and diagnostic criteria used. And for example, just to focus on race, patients of African ancestry who develop lupus, for example, lupus nephritis, will have more severe disease histology at presentation. They have some genetic factors that may be associated, like APOL1. And they are more common, have anti-Smith antibodies, anti-RMP antibodies present at the time of diagnosis, suggesting more severe disease histology. So who is at risk for LN? And you can kind of see here by these two graphs. This is looking at the top right figure is looking by ancestry category. In red is those of African ancestry. And then ethnicity with Latino population in orange, and then Caucasian in blue. So the percent developing LN after diagnosis of SLE, you can see the highest risk is in those of African ancestry or Latino population. Yeah, and then in patients, if we look at who's at risk for developing end-stage kidney failure, this study looked at risk of end-stage kidney failure, doubling of serum creatinine within 3 years, or death within, so it's a composite outcome within 3 years of LN diagnosis. And again, by and far, you can see the highest risk is associated with African ancestry or Hispanic relative to Caucasian patients. And the point being here is that, you know, in the United States, historically, a lot of this was attributed to socioeconomic factors, but in fact, it's not just that, right? I mentioned the more severe disease histology and maybe perhaps some genetic influences, and that's still unraveling, and more is needed to be determined, and more research is needed, specifically looking at genetics in large data sets of lupus nephritis. But hopefully that research is ongoing, and hopefully we'll have some data on that in the near future. Okay, so I'm not going to talk in great detail about the pathogenesis of SLE and lupus nephritis, but I did want to at least comment on what we know about it. So we all know that lupus is a systemic inflammatory autoimmune disease that involves multiple organs, and really any organ. It's heterogeneous in presentation, and its pathogenesis is heterogeneous as well. It occurs in genetically susceptible individuals, and to date, over 80 gene variants have been identified to be associated with SLE, and several, and these are through large GWAS studies looking at lupus. They were able to identify several genes that may be associated with lupus nephritis, including the APOL1 gene, and then also the Fc gamma receptor 2A has been associated with lupus nephritis in patients of African ancestry. So what you see is after this genetic susceptibility, there needs to be a second hit, whether it's an infection, sunlight, something like that, that leads to loss of immune tolerance and immune dysfunction, and the development of pathogenic autoantibodies and immune complex development in reaction to cellular and nuclear antigens. And these immune complexes can develop in circulation, or they can develop in situ within the kidney. This activates both the innate and adaptive immune system, leading to complement activation and T and B cell co-activation that perpetuates this autoimmune phenotype. And basically, once this occurs and the disease becomes activated, you see an infiltration of immune complexes, activation of multiple different dysregulated immune pathways, responding to cellular and nuclear antigens, and that leads to target damage within a tissue bed, including the kidney. So as we move forward, and with that as our background, let's start with a case presentation. And I'll refer back to this case a couple of times just to kind of focus our discussion. So this is an 18-year-old female who presents with several concerns. She reports facial rash, joint pain, shortness of breath, chest pain, and fatigue. Hair is falling out, notices her legs are swollen, her urine is very bubbly. 1 month prior, she was going to the gym regularly, running 2 to 3 miles per day. Her urinalysis shows large blood, 3+ protein, and serum creatinine has increased from 0.6 to 0.9 milligrams per deciliter. Her urine microscopy is reviewed and shows these characteristic features. You can see the dysmorphic red blood cell and a red blood cell cast. So how does lupus nephritis manifest clinically? So the presentation for lupus nephritis and is really, and the evaluation has really not changed. It's the same things that we think about. You look for the clinical manifestations of SLE, and clearly our patient in that case presented with multiple manifestations that'd be worrisome for lupus. Lupus nephritis, and patients with lupus nephritis, about 70% of them will have anti-double-stranded DNA antibodies, so certainly not everybody. Those antibodies, though, do not necessarily correlate with disease activity all the time either, so you have to be careful with interpretation. Anti-C1q antibodies get a lot of discussion in the literature, but are not routinely tested, and the testing is not routinely available. They tend to be fairly specific for lupus nephritis, but to date have not been employed into clinical practice. So when they're present, if they're tested, when they're present, it's highly suggested that lupus nephritis may be present, but they're not really followed, and there haven't been really large studies looking at anti-C1q antibodies in the setting of lupus and lupus nephritis. Serum C3 and C4 are commonly measured. Lupus itself is a disease of classical complement pathway activation. And both factors, C3 and C4, tend to be low in the setting of active SLE and LN. But again, they're not perfect measures, and perhaps trend is more important than the absolute measure. And while they can serve as some surrogate markers for disease activity, there are some limitations there as well. So when we think about clinical manifestations of LN, by definition, everyone has proteinuria. Clinically, that's how lupus nephritis is suggested or defined. Nephrotic syndrome occurs in approximately 50% of cases, and microhematuria is present in most cases as well. Impaired kidney function is depending on the definition of impaired kidney function. And if you remember, patients with lupus tend to be younger and female, and their creatinine values tend to be on the low side to begin with. So even mild impairment needs to be you need to be clued into, but may not be recognized. So this percentage may be actually on the lower side. Hypertension and RPGN is not as common findings, but tubular abnormalities are very, very common. So how do we approach patients with lupus nephritis? So the common approach is a patient presents with proteinuria, typically greater than or equal to 500 milligrams per day. You evaluate the urine sediment, and it's suggestive of an active nephritis, or they have decreased kidney function, which is suspected to be attributable to lupus. And then the gold standard remains you perform a kidney biopsy. And on kidney biopsy, you're looking for several features to differentiate what is going on in the kidney. And it's not just to identify the class of lupus nephritis, but also to make sure the patient doesn't have another cause of kidney injury, because in about 5% of cases, a non-lupus nephritis kidney disease is present. And in that scenario, in about 1% of cases, it may be a lupus podocytopathy, such as minimal change phenotype or FSGS. Collapsing FSGS is also possible. But then there's also thrombotic microangiopathy, which is a worrisome feature, of course, and can lead to rapid decline in kidney function. And unlike most diseases, there's at least three different conditions that can lead to thrombotic microangiopathy in the setting of lupus. You have atypical HUS that can be associated with lupus, TTP, as well as antiphospholipid syndrome that we all will know. And so it's important not only to understand that if there is a thrombotic microangiopathy that is going on, and then look further to differentiate which might be occurring, because that would actually impact management. So then we can break down lupus nephritis into proliferative and non-proliferative forms of LN. And I won't spend a lot of time here because I'm sure this is review for this group, but the non-proliferative forms, such as class 2 and class 5 lupus nephritis with subnephrotic range proteinuria. In these cases, traditionally, we approach these patients conservatively with focus on immunosuppression to be focused on the non-renal SLE manifestations. In class 2 would really be defined with just mesangial immune complexes without subendothelial involvement. In class 5 would be, of course, subepithelial deposits, but perhaps they're sparse and the proteinuria level is low, so nephrotic syndrome is not seen. The most worrisome features, of course, the proliferative forms of lupus nephritis, class 3 and 4. These are somewhat arbitrary definitions that are not truly based in evidence, but both are concerning and can lead to poor outcomes if not treated appropriately. And when we think about class 3 and 4, we really want to differentiate active lesions versus chronic lesions, because the chronic lesions obviously the disease has already occurred and you don't want to over immunosuppress the patient. Of course, mixed class 3 or 4 plus 5 can occur, where you have both proliferative mesangial subendothelial deposits, and then you also have subepithelial deposits. And then nephrotic class 5, which can also be associated with poor outcomes. So you want to treat that with immunosuppressive therapy. On immunofluorescence, the classic findings is this full house immunofluorescence, which is polyclonal IgG, IgM, IgA, C3 and C1q, suggestive of both classical and alternative pathway activation. And then, of course, this is all polyclonal. So these are the classic findings. They're not necessarily specific for lupus nephritis, but this is what we look for on kidney biopsy. So I'm not a pathologist, so I'm not going to go into too much detail about the ISN RPS classification of 2003, other than to highlight a couple of deficiencies of this classification. First, it didn't consider tubular interstitial or vascular lesions. And it lacks sufficient quantification of disease activity and chronicity. So that was not routinely done. And so there was a lot of heterogeneity across reads from pathologists. This actually impacted clinical trials. And that's kind of what led to the centralization of pathology for clinical trials, because they noticed there was great discrepancies between local reads and central reads. And then these descriptive categories didn't lack some clear prognostic value. And so in 2018, the same group or this similar group of people, pathologists came back together and provided some revisions, and with the hopes of simplifying the terminology and improving clarity. And I think one of the most important things that came out of this is they recommended routine use of activity and chronicity index scores on every biopsy. They also emphasized the importance of research at looking into tubular interstitial lesions and vascular lesions. And their goals here were to reduce the variability in reporting and determine the value of histologic metrics. And when we talk about activity and chronicity, this plays a role when we think about repeat kidney biopsies and potential outcomes. And here are the different markers that they're looking at for activity and chronicity. I won't highlight all of them other than to say that the activity score is out of 24 and chronicity score is out of 12. And these are important metrics to be included in the pathology because they actually help, they may help guide your treatment decisions in lupus nephritis. So let's get back to our patient. So this patient had a 24-hour urine that showed 3.5 grams per day proteinuria, underwent a kidney biopsy that showed classic class 4 lupus nephritis, had a high activity index of 10 out of 24, and a chronicity index of 2 out of 12. So the next questions become, how should we counsel this patient and how should we approach treatment? So most importantly, we should stop and just understand the implications of having lupus nephritis, right? So time is nephron. I'm sure we've heard this statement, and it's a very important statement in my mind because no matter what the cause of kidney disease, nephron loss is what we want to prevent, right? And with the first flare of lupus nephritis, nephron loss can occur quickly and chronic damage can occur quickly. And there's been studies that have shown chronicity index rising even with treatment control within the first 6 months of LN diagnosis. And these were based on repeat biopsies. And of course, if we don't get the disease under control, you're going to get ongoing nephron loss, which will lead to end-stage kidney failure in a more rapid pace. Versus if you're able to get disease control, you can kind of parallel slow nephron loss that you might see with aging. And what's the importance of all this outside of we want to control lupus and lupus nephritis is we want to limit chronic kidney damage and its associated complications with a focus, of course, on cardiovascular disease. Because patients with lupus already have a significantly higher risk for cardiovascular disease and early cardiovascular disease. And then when you add chronic kidney damage on top of it, you can imagine how that risk amplifies. And so it's critically important to not only get the disease under control, but then maintain control long-term. And we'll talk about some of that as we move forward. Here's a study that looks, this was a study done in 2008. It was based off older data. So for those who are aware and reviewed the study that looked at plasma exchange for severe lupus nephritis, the data comes from that study. And that study was a prospective trial that compared standard of care treatment at that time with cyclophosphamide and steroids, plus minus plasma exchange for patients with severe lupus nephritis. And they found that there's no difference with plasma exchange. And then what they did was they followed these patients and then they said, okay, well, no one's really looked at the value of partial response. You know, if you look at our LN trials, we say total response. If you look at the ALM study, they looked at total response. But, you know, we really need to think about partial response because it's not the same as complete response. So in this study, they looked at complete, partial, and no response. And this is after 5 years of study enrollment. They stratified patients by complete, partial response, or no response. And complete response was less than 0.3 grams per day proteinuria, stable kidney function. Partial response was 50% reduction in proteinuria. And what you can see here is that they were looking at kidney dialysis-free survival. And 92% of patients who achieved a complete response were doing great 10 years after study entry. Meanwhile, those patients who achieved a partial response, only 43% of them were dialysis-free at the 10-year mark. And of course, those with no response did very poorly. So just to highlight and impress upon the importance of achieving a complete clinical remission over a partial clinical remission. Though a partial is better than no response, it's not nearly as good as a complete response, and that's where our focus really should be. So when we think about treatment of lupus nephritis, as we were linking back to our case, what are our options for lupus nephritis management? So first, this is the standard approach. If we look at the KDIGO guidelines from 2012 and updated, and the data that's out, and really historically what we've done is, cyclophosphamide and high-dose steroids for induction therapy, followed by a maintenance therapy. And then of course now mycophenolate, Mofetil, this was since 2006, 2007, after the ALM study, mycophenolate Mofetil came into the picture. And so with the EuroLupus study and the ALM study, we had two different formulations of, three different formulations of cyclophosphamide. First with the NIH study with the high-dose cyclophosphamide, then, then PO cyclophosphamide, which was historically used, and now the low-dose cyclophosphamide, which is 500 milligrams every 2 weeks, or mycophenolate Mofetil. And largely, mycophenolate Mofetil became the standard of care for the most part after the ALM study. And then maintenance therapy with mycophenolate Mofetil or azathioprine. And you can see here that the treatment for what we would classify as induction therapy for 3 to 6 months, followed by a maintenance therapy, which I put here as greater than 24 months. But again, these are relatively arbitrary definitions that are not based on evidence. The reality is we don't know how long to maintain, keep maintenance therapy on for in a disease that is not curable and can relapse. And if you look at the EuroLupus study, those patients maintained therapy for 10 years throughout the entirety of the study, and they had relatively good outcomes. So, but this is a general recommendation based on expert opinion that at the very least, patients should be in sustained remission for greater than 24 months before considering treatment withdrawal for patients with lupus nephritis. And of course now, how are we, based off this therapy and this standard of care, what do the outcomes look like? Well, not great, right? So if you look across clinical trials and you look at 12-month complete response rates, you can see these are 4 large trials, and the best clinical response, complete clinical response at 12 months is 40%. And then if you look at the ALM study, right? So this is looking at 24-week partial and complete response. You see the partial response and the total response, 53 and 56%. But if you look at complete remission, 8 and 9%, so dismal at 6 months. And then there's this large meta-analysis that was done. This was actually a pretty nice study that looked at end-stage kidney failure outcomes over decades. So they looked at different cohorts and they basically evaluated how treatment evolved. And you can see that the risk of ESRD was declining steadily after the introduction of cyclophosphamide. But then some period here, and this is just tends to be around 2006, that plateaued. And perhaps even more recently, we're seeing a trend towards worse outcomes. And of course, we don't know exactly why that is, but of course, also around this period, we're starting to use more and more mycophenolate too. So that's not to say one or the other, but it is to say that we're not seeing the same improvement or reduction in end-stage kidney failure as we would like to see. So ultimately, we need a better solution to improve renal response rates in lupus nephritis. And now we do have 2 approved therapies for lupus nephritis. And how should we consider these in the management landscape of lupus nephritis? And this is a question that's being asked over and over again. And I'll tell you that more data needs to come out for us to really know how to incorporate these therapies into the landscape. But what I want to highlight now is just not just the approved therapies, but the mechanisms of how we think these therapies might be helpful in the landscape of lupus nephritis. First, let's talk about the evolution of B-cell therapies in the LN. So when lupus, like 20 years ago, 30 years ago, lupus nephritis was considered a T-cell disease. Then there was a huge emphasis and an interest in learning and focus on B-cell therapies. In particular, you had large studies looking at anti-CD20 and anti-CD19 therapies, and this is rituximab and ocrelizumab. I'm sure many of you have heard about the LUNAR study that was done, and there was also an Explorer study in SLE looking at rituximab and looking at the value of rituximab as a treatment for lupus nephritis. Now, these were add-on studies, add-on therapies. And the LUNAR study was a largely negative study that showed that rituximab on top of standard of care did not change clinical response rates. And in the BELONG study, which was ocrelizumab, a CD19 therapy, that study was halted because of increased infections. And so both studies ended up being failures. And because of that, there was hesitancy to use rituximab, but there was a lot of interest still in B-cell depletion, just based on mechanistically the idea behind immune complex generation, autoantibody production. The thoughts there were that B cells should continue to be a prime focus. And there were several cohort studies, observational studies that found that rituximab was effective in resistant LN. So because of that, there was still a lot of interest in rituximab. And along came two additional B-cell modifying drugs, Obituzumab, which is another anti-CD20 therapy that I'll talk about in a little bit, and then boliviamab, or Benlysta, which is an anti-BAFF therapy. And both have had positive clinical trials, which we'll talk about here in the next several slides. So first, what is B-cell activating factor, or BAFF, BLISS? So BAFF is a TNF ligand cytokine that's produced by hematopoietic cells and plays an important role in B-cell maturation, activation, and survival. BAFF itself has been shown to be overexpressed in circulation of patients with SLE, and overexpression of BAFF favors an autoreactive B-cell population development and survival of those autoreactive B cells. It's been shown to promote plasmablast production when B cells are low, and stimulates T follicular helper cells, as well. As you can see, the BAFF receptors are present on plasmablasts, T follicular helper cells, and B cells. There are three different BAFF receptors, the BCMA, the BAFF-R, and the TACI receptor. All of them have their own roles, and a medication like boliviamab targets them all. Okay, so what is boliviamab? Boliviamab is a humanized monoclonal antibody that inhibits BAFF from its binding to its receptors. It inhibits in doing so, the thought is that it inhibits B cell survival and reduces the differentiation of B cells into immunoglobulin producing plasma cells. So back in 2009-10, there were two large phase 3 trials that studied boliviamab in lupus. There was over 1,600 patients in these studies. And what they found was that the dose of 10 milligrams per kilo was superior to placebo as measured by this composite lupus activity score that encompasses the SLEDAI, the BILAG, and the physician global assessment. So boliviamab was FDA approved for treatment of lupus in 2011. And when they looked post hoc at the potential value of boliviamab in patients enrolled in these studies, and there was a small percentage of them enrolled in these studies with lupus, who had lupus nephritis, they found that renal flare rates were less compared to placebo, and the lower dose boliviamab arm in patients who had lupus nephritis who were treated with boliviamab. So you can see here, this is post hoc. Each group had over 500 patients, and the greatest rates of renal flare, and this was statistically significant, was in the placebo group relative to those who had 10 milligrams per kilo dose of boliviamab in these SLE studies. So that was the impetus that led to the BLISS-LN study. The BLISS-LN study was a phase 3 study, and it took patients with active lupus nephritis, class 3, class 4, mixed, or class 5, and they randomized those patients 1-to-1, and induction therapy was left to the investigator. All patients received high-dose corticosteroids plus cyclophosphamide, followed by azathioprine for maintenance, or high-dose corticosteroids plus mycophenolate, followed by mycophenolate maintenance therapy. So they started on induction therapy at day minus 60, And then they were randomized either placebo plus standard of care or boliviamab at day 0 and then followed for 104 weeks in a double-blind fashion. And the primary endpoint here was a primary efficacy renal response at 104 weeks, and a key secondary endpoint was complete renal response. All patients by week 24 had to be on less than 10 milligrams per day prednisone. And so why primary efficacy renal response? So 2 things about this. First, this was not the original primary endpoint. This primary endpoint was modified and developed before unblinding, but in the middle of the trial, and it was based off data, the literature that came out after this trial had started, and I'll highlight that in the next slide. But ultimately, what this is, the primary efficacy renal response, is a urine protein creatinine ratio of less than 0.7. So less strict than what we commonly use for complete response in the setting of lupus nephritis. The GFR had to change no more than 20%. Below pre-flare value, and had to have greater than or equal to 60 mLs per minute and no rescue therapy. Complete renal response then was urine protein creatinine ratio of less than 0.5, eGFR no more than 10% below pre-flare value, and greater than 90 mLs per minute and no rescue therapy. And overall, what you see in both groups at 104 weeks favored the boliviamab arm compared to the placebo arm. You can see the PERR and the CRR were 32 and 20% in the placebo group or standard care only group, and then 43 and 30% in the Benlysta group or boliviamab group. And you can see the odds ratios here, and these were statistically significant. So why the PERR? Why the primary efficacy renal response? So as I mentioned, the usual definition of proteinuric response is less than 0.5 grams per day. And in clinical trials, they've used a number of different clinical response criteria, so there's no standard really. But whether this cutoff best predicts clinical outcomes long-term was questioned in 2 large analyses of patient cohorts from prospective clinical trials that were then retrospectively reviewed. The first was a Eurolupus cohort. This was done by Maria Delera, this group where they evaluated common clinical markers for LN at 1 year to see which one of those markers would best predict long-term kidney outcomes. And they tried to use composites and add the different markers together. And what they found was that after 12 months, achievement of a proteinuria level less than 0.8 grams per day best predicted good long-term renal function with an 81% sensitivity and 78% specificity. In another study by Tamaru, they looked at the maintained nephritis cohort. This was 90 patients, and they found at 12 months of treatment, achievement of proteinuria level less than 0.7 grams per day best predicted good long-term renal outcomes. And when they added serum creatinine or hematuria to these metrics or complement, it didn't improve the sensitivity or specificity of either study, basically suggesting that proteinuria at 1 year is our best marker for long-term outcome. And in fact, maybe we don't need to be as strict with our proteinuria guideline. And that's what led to the change in the outcome measure for the BLISS-LN study. Okay. So I mentioned the top line results for the BLISS-LN study. We'll go through this quickly. But because I really want to get to the post hoc and the subgroup analyses. So here, this is a PER. You can see, and what I really want to highlight here is how long it took. In the first 6 months, there was really no difference between standard of care and the boliviamab group. And this is for CRR and PERR. The separation started after 6 months and then continued to the 104 week or 2 year time point in both groups. So just suggesting that it takes time for B-cell therapy to actually have an effect on outcomes here in lupus nephritis. And when we look at the subgroup analyses, there's several things that we can look at. So if you separate by baseline proteinuria level, it's interesting here to note that those patients who had lower levels of proteinuria, so this is less than 3 grams per gram on urine protein creatinine ratio, they tended to have far better outcomes, or they tended to do better with the boliviamab treatment. However, those who had heavy levels of proteinuria, so greater than 3 grams per day, it didn't seem that the boliviamab didn't seem to stand out. Not exactly sure why, and more research probably needs to go into this, but in those patients with high levels of proteinuria, there was not a signal here that favored the boliviamab group. What about when we broke it down by class? So when we break it down by class, those with proliferative or mixed lupus nephritis, and of course this was a bigger population, they certainly seem to have favored the boliviamab group over standard of care. but it did class 5, and this was a small number. And I'm not sure that then this study wasn't, powered to study class 5 alone, of course, but they did not seem to stand out. Maybe that goes along with the higher levels of proteinuria, proteinuric patients. And then we break it down by treatment. You see that those patients who were treated with mycophenolate tended to have a better response, but it wasn't as clear, especially with the CRR, in those who were treated with cyclophosphamide. Of course, a smaller number of patients were treated with cyclophosphamide, so perhaps that played a role in why the signal was not as readily seen in that patient population. So overall, and then when we look at time to first renal flare, that favored the boliviamab treated group. So this is looking at renal flare, and this is from 24 weeks on. Across the board, you see, and especially in both treatment arms and in proliferative lupus nephritis, patients who were treated with boliviamab had less risk for renal flare relative to those who were treated with standard of care only, suggesting that boliviamab may be best positioned, frankly, in preventing renal flares when we think about how we're going to use it in the setting of lupus nephritis. Okay, so let's move on and quickly briefly talk about obinutuzumab. So obinutuzumab was studied in a phase 2 trial, randomized phase 2 trial comparing obinutuzumab plus standard of care versus placebo in standard of care. And this was 125 patients. And this was reported at ASN 2020, and there's actually a phase 3 study that's ongoing right now. So what is obinutuzumab? So obinutuzumab is a type 1 anti-CD20 therapy. It's a type 2 anti-CD20 therapy. This was developed by the same company that owns rituximab. And head-to-head, obinutuzumab was compared to rituximab for treatment of B-cell lymphoma and was shown to be more potent and more effective therapy than rituximab in the setting of B-cell lymphoma. So then they decided to study it in lupus nephritis. And there's a little bit of difference in terms of how it works. It has increased potency and increased antibody-dependent cytotoxicity that results in greater direct cell death and B-cell depletion. So the thought was that in the rituximab studies, the LUNAR study, maybe we weren't getting enough B-cell depletion. In fact, that's what tended to happen in the LUNAR study. They got incomplete B-cell depletion. And then the obinutuzumab study, they got complete B-cell depletion with obinutuzumab. And so the study here was a 70-week, actually 104-week study with endpoints looking at 36 weeks, 52 weeks, and 76 weeks, looking at complete renal response in patients who had proliferative lupus nephritis with greater than 1 gram per day proteinuria. This design was very similar to the design of the LUNAR study, except for it was extended out to 104 weeks where LUNAR stopped at 52. And all patients had mycophenolate and prednisone as their background therapy. So what do we see? So again, patients got two courses of obinutuzumab. Renal response rates were pretty similar in the first 6 months. But then after 6 months, you see a dramatic change in renal response that continued and persisted over the 76 weeks. And actually, I don't have the data here, but a 104-week period where the obinutuzumab group, and this was statistically significant at 36 weeks, 52 weeks, and even more so at 76 weeks, tended to have continued improvement in response and relative to the standard of care group, suggesting that obinutuzumab as a strong B-cell depleting agent may be an effective therapy to consolidate treatment and help attain and potentially maintain remission for patients with lupus nephritis. So how do we summarize these B-cell depleting trials? So despite the early failures, there's obviously interest in anti-B-cell treatment, and it's commonly used in the setting of lupus and lupus nephritis. Boliviamab plus standard of care was greater than standard of care alone, inducing and maintaining remission over a 2-year period. The benefit of boliviamab in addition to standard of care in patients with high-grade proteinuria or severe disease may be less certain. Obinutuzumab plus standard of care was greater than standard of care alone at 52 weeks and 76 weeks, and it more effectively depletes B cells than rituximab does. The benefits of B cell depletion take several months to realize and maybe more effectively improve and maintain treatment response long-term. They may be good therapies for consolidating treatment. The data for obinutuzumab is exciting, but it's preliminary, and the phase 3 is underway, so we need to see what the data from the larger diverse trial in the phase 3 shows. So now I want to move on and switch gears. We talked about B cells, and now let's talk about T cells. So we're all very familiar with calcineurin inhibitors in the nephrology space because we're comfortable and use them commonly for setting kidney transplant, as well as other glomerular diseases. So we know that calcineurin inhibitors have this proposed dual mechanism of action where they block T-cell mediated immune responses and inflammation, but also have this proposed mechanism where they stabilize podocytes by working through stabilizing synaptopodin and the actin cytoskeleton, so reestablishing the podocyte, and in doing so, perhaps may help reduce proteinuria. So there might be a dual mechanism of action here where they may be beneficial in the setting of proteinuric diseases and inflammatory diseases such as lupus nephritis. So there was an initial study done in China that looked at a multi-target regimen, and there's been several studies from 1980 on looking at calcineurin inhibitors as a treatment for lupus nephritis, several different cohort studies. But this was a randomized controlled study from China that compared tacrolimus plus mycophenolate. And you can see their lower doses here of the, of the mycophenolate at 1 gram per day versus IV pulse cyclophosphamide and steroids, and evaluated for complete renal remission as defined as urine protein less than 0.4 grams per day, normal renal function, and active urine sediment. And what they found across the board was that patients who had the multi-target therapy had a greater overall response, so 46% response, complete response, relative to 26% with the IV cyclophosphamide group. And they broke it down by class. It tended to hold across the board. The one caveat being they did see more infections in the multi-target group with 7 cases of pneumonia versus 1 in the cyclophosphamide group. And one patient had a doubling of serum creatinine in the multi-target group with calcineurin inhibitor. So the question remaining whether, using this therapy with multi-target, multiple treatments, could that be a higher risk for infection? And of course, with use of calcineurin inhibitor, should be worried about poor kidney outcomes because of the effect of calcineurin inhibitors in these patients. On the piggybacking off that original study in China, and there's longer-term data I didn't mention from this study that showed in a small cohort of patients that had histologic remission with the multi-target therapy, but also that after 2 years of follow-up, the cyclophosphamide group actually caught up to the multi-target group in terms of overall response. So, suggesting initial response was better with the multi-target group, but with time, that cyclophosphamide treated group had similar outcome. So that just goes back to that proteinuria reduction factor that may happen with the calcineurin inhibitor and how we measure complete response. So that led to the voclosporin study. So what is it? So voclosporin, there's 2 trials here, a phase 2 study and then a phase 3 study. And I'm only showing the phase 3 study because it basically replicates the phase 2 study in terms of outcomes. So very consistent design and response. So here you're looking at voclosporin, which is a next generation calcineurin inhibitor, and their primary endpoint was 52-week response rates. And it was voclosporin versus placebo in addition to standard of care, which is mycophenolate plus oral corticosteroids. The important thing about this is that the corticosteroid dosage, the prednisone dose, was far reduced at starting in the voclosporin group, starting at, and I don't know why my mouse is not working here, but the voclosporin group had in both cases, both groups, they started at a very low dose of steroid, 25 milligrams per day, with a rapid taper. You can see if you look at the green bar chart at the bottom, you can see by week 6, most patients were down to 5 milligrams per day, or it was forced taper, so they were down to 5 milligrams a day and 2.5 milligrams per day by 8 weeks, and almost off steroids by week 12. Okay. So 178 patients received placebo, standard of care. 179 received voclosporin, 23.7 milligrams twice daily. And you can kind of see the algorithm to the right. So why voclosporin? So voclosporin is really a derivative of cyclosporin with a modified functional group on the periphery. And so it impacts the binding to the latch region on calcineurin. It makes it more potent and allows for a more predictable PK-PD relationship such that you don't need to monitor levels. It has increased potency, but better clearance, so the metabolites of the voclosporin don't last. And so the thought is that there may be more potency, but less toxicity. So you don't need weight-based dosing. And in studies where they compared and looked at other calcineurin inhibitors versus voclosporin, which there's limited data on this, but it seems that there's less risk for diabetes and improved lipid profile. And in fact, there's some data to suggest maybe the lipids actually go down, but improved lipid profile. And it does not interact with mycophenolate levels. So the use can be done in combination. Okay. So what were the outcomes from the phase 3 voclosporin versus placebo study? So similar to the phase 2 results, they found early, complete, and overall response at week 24 weeks, 32% versus 70% in the voclosporin group versus the placebo group. And then that was sustained at 52 weeks in both groups. So this is looking at complete renal response, and then this is looking at partial response. In the bar graph to the right is partial response, bar graph to the left is complete response. And you can see at 24 and 52 weeks, not only is this, you have early remission, but you have sustained remission. But still the complete response rates here are less than 50%, even at 52 weeks, you see 41% in the voclosporin group versus 20 to 23% in the placebo group. And importantly, the adverse events in leading to any severe adverse events were similar between the two groups, with less treatment or adverse events leading to death in the voclosporin or the multi-target group versus the placebo group. There were more adverse events leading to death in the placebo group. And disease-related AEs and any serious adverse events were similar across the board. So one of the main differences between a calcineurin inhibitor and a B-cell therapy is time to proteinuric response. And you can see that here across the board, starting at, these are days. And you can see the proteinuric response is fairly rapid in the multi-target group. Really within the first month and certainly within the first 3 months, we're seeing a difference compared to standard of care, and that's persistent and continues over the course of the duration of the therapy. And overall, these were all statistically significant. Both complete and partial response and overall response was greater in the multi-target group, similar to the Asian study, frankly, with the tacrolimus. But this was in a multi-ethnic, multiracial population. And just going to subgroup analysis, you can see that across the board here, for the most part, with the exception of patients, like white patients or Caucasian patients, in every other subgroup, the multi-target group did better. This include Asian, Black, and Latin American or Latino populations. The other thing I want to highlight, which was interesting, similar to the BLISS study, you didn't see a signal for patients with class 5. Now, again, this is a smaller population of patients. It wasn't powered to study class 5, but in these 50 patients, there wasn't a difference between the placebo or the multi-target therapy. Overall, across the board, favored both male and female. It didn't matter, age didn't matter. And in high-risk groups, the multi-target therapy did better. So what are some challenges to incorporating the new therapies in lupus nephritis? One, we lack effective biomarkers to help us guide like which therapy to use and when. We're lacking at least still some long-term safety data. And there's some big burdens that we have to think about. One, the burden of immunosuppression. It remains the same or increases. We're not just adding, supplementing one therapy for another. We're adding more therapy to our patients, which can increase risk, of course, but also increase cost. These therapies are not cheap, and they're hard to attain, certainly. And at least in the setting of voclosporin, it's increased pill burden. So you can imagine if you take voclosporin, it's to get to 23.7 milligrams per day right now, that's 6 tabs a day. Add that to the 4 or 5, 6 tabs you're taking of mycophenolate and prednisone and maybe hydroxychloroquine. And that can become a lot for a 22-year-old who needs to take these medicines for their lupus nephritis. So these are some real life limitations to these new therapies that need to be considered. And the other thing I want to highlight, even with these new therapies, while we're doing better and we have positive clinical trials, so now we have more tools in the toolkit, the complete clinical response rates are still suboptimal at less than or equal to 50% at 12 months. So we still need to do better. We still need better therapy. We still need more research. So let's go back briefly to our patient. How do we start? How do we think about treatment for our patient? We started the patient on mycophenolate. They received 2 IV pulses of methylprednisolone, and they followed by a moderate dose prednisone with rapid taper. After 3 months of treatment, the serum creatinine normalized, but proteinuria remained elevated at 2.5 grams per gram. Urine sediment remained active. The patient was started on a calcineurin inhibitor in addition to the mycophenolate, and the prednisone taper was continued. At 6 months, serum creatinine normalized, 24-hour urine protein was down to 0.3 grams per day. The serologic SLE markers normalized, complete clinical response was achieved. The patient's now in remission. So how should we counsel the continued treatment? And when can we consider withdrawing immunosuppression? So I want to finish up by just highlighting some of these points and talking about these two key questions. So when I think about, and this figure, I credit to Dr. Brad Rovin, who's a mentor and colleague, but I like it because it gives a picture of how I like to think about lupus and lupus nephritis. So at the bottom of this wheel is when we see patients with lupus nephritis. It's clinically apparent. They have proteinuria, nephritic urine sediment. You want to think about biopsy, cat's out of the bag, so to speak. The disease is active. It's the dysregulated immune system is going nuts. Here is when we think about using our anti-inflammatory therapy. I like to think this is where our best value may be for calcineurin inhibitor, especially in a setting of heavy proteinuria. Maybe in the future, we might be thinking about anti-complement therapy in this window. But here we want to suppress the inflammation, right? And this treatment might be targeted for about 3 to 6 months, with hopefully we have some clinical improvement. And then we want to consolidate our treatment. So when we initially think about induction and maintenance therapy, what we should be thinking about is suppressing inflammation and then targeting autoimmunity. And we want to consolidate our treatment. So we want to hit B cells and T cells. We want to, and then we want to keep that disease in remission. So one way to think about the new therapies and how we might incorporate them is you can, as I showed you, you get a faster proteinuric response with CNI. So maybe that's a time to think about it is when the disease is first active. But then maybe it's not either or. Maybe it's one and then the other. Maybe we should think about stratifying our treatment. It seems like B-cell therapy works to prevent disease relapse, works to consolidate therapy and help improve response over time, but it takes time to work. So perhaps, and this is just one approach, you could think about using your steroids, anti-inflammatory therapy, CNI up front, and then incorporating a B-cell depleting therapy at the 3 to 6 month time point to suppress this autoimmunity that continues over the course of this cycle. And then the next question should be, how long should this therapy go for? And when can we consider stopping this therapy, or should we even stop this therapy? So just kind of give you an idea of, this kind of wheel of disease where you have subclinical disease, clinical disease, and subclinical disease, and how we might best target or use our therapies. But when we think about treatment taper or withdrawal, here's a study that looked at this and looked at patients who had sustained renal response for greater than or equal to 5 years or less than 5 years. And what you find is those who have, and this is not surprising, if you have a sustained clinical response of greater than or equal to 5 years, you had less death, you had less damage, and you had less progression to end-stage kidney failure, doubling of serum creatinine, significantly less than those who had flares within 5 years of initial diagnosis. So when we think about withdrawing therapy or tapering therapy, we don't have any good biomarkers right now to kind of help us do that yet. Nothing validated, at least. Additionally, there's no good studies that tell us how long is long enough and who or when should we start to taper or withdraw therapy, which can lead to some anxiety both with the patient and the provider. So maybe this is a good time period where we could think about thinking about a repeat kidney biopsy. So there's a couple studies that have looked at this, and here's one study where they had 56 eligible patients, and all patients were treated for their active lupus nephritis, were on maintenance therapy with mycophenolate for greater than 30 months, and had sustained clinical remission for greater than or equal to 12 months. A kidney biopsy was repeated in all these patients. These are 44 patients, and they were tapered off immunosuppression, okay? And they followed up for 24 months. And what they were evaluating for was flare and association of flare to histologic disease activity. And here's what they found. So this is a dot plot looking at those who develop flare versus no flare based on activity index. So overall, 44% of patients at repeat biopsy, this is after sustained clinical remission for 12 months, had histologic activity on the repeat biopsy. And there were 11 flares in this group over the 24-month follow-up. And what you can see here in those who flared, 9 out of 11 had evidence of activity, disease activity, at that repeat biopsy. And if you look at those who had a histologic remission, so no activity at repeat biopsy, only one of those patients flared. And in general, an activity index of greater than 2, all patients with activity index greater than 2 had a flare, suggesting that perhaps looking at disease histology might be a good way to help us determine who should be continued on immunosuppression, but then also who we might be able to prevent over immunosuppressing, because of course we want to prevent the risks associated with that. And that will avoid unnecessary toxicity in patients with histologic remission. Now then, in a second study that looked at this similarly, a study of 42 patients with proliferative lupus nephritis all underwent repeat kidney biopsy at flare, or biopsy at flare, and then a protocol repeat biopsy 24 months after the first biopsy. And in this group, cohort, what they found was that patients who had high activity index at repeat biopsy, which was defined as an activity index greater than 3, all of those patients, that activity index of greater than 3 was predictive of renal flare. And then those patients who had a chronicity index greater than 3 at repeat biopsy, that predicted a poor prognosis, which is not all that surprising. But that's to highlight the possibility of histologic activity score and perhaps the importance of reporting this histologic activity score, both at first biopsy and then potentially in patients who have sustained remission, perhaps using it, using a repeat kidney biopsy to kind of help facilitate decision-making on longer-term treatment. Of course, this would be nice if it was done in a multi-ethnic, multiracial, larger randomized control trial. And so maybe it will be. And of course, this is nice and we can do this, but it'd be more ideal to have non-invasive biomarkers to help us guide this. And there are some data on that, which I won't get to today, but I'm happy to chat about that in the discussion after the talk. And so to summarize and to finish up, standard of care of lupus nephritis is evolving. Combination therapy with either anti-BAFF or calcineurin inhibitors seems to improve clinical response compared to standard of care. A better understanding of how these therapies are best applied is still needed. Several factors need to be considered when deciding when and how to apply these therapies. Steroid-reduced protocols have emerged and are now favored in most cases, with a couple caveats. So I think in general, we overuse steroids in the setting of lupus nephritis. However, that does not apply necessarily to patients who have RPGN or crescentic disease, because those patients are largely excluded from these clinical trials. So please keep that in mind when considering steroid-reduced protocols, though I would favor that in most cases of lupus nephritis. And while current therapies are an improvement, there are considerations: pill burden, infection risk, cost. Additionally, still greater than 50% of patients don't achieve a complete clinical response with current treatment. So we need more research, we need more therapies, we need better overall treatment algorithms. Sustained long-term remission is associated with the best outcomes. Assessing for histologic remission may help guide treatment withdrawal decisions in patients with sustained clinical remission. And with that, I am happy to conclude and certainly happy to entertain any questions you guys have. Thanks for your time. And again, thanks for the invitation.
Thank you, Dr. Samir. That was really wonderful. I would like to open the floor for questions, and we already have 2 in the chat box. Probably we could start with those. And we have a comment from Dr. Joan Caroli, who wants the ranges for low versus high doses of steroids.
Yeah. So I think that's a good question. So traditional dose of steroids, I would say, is like 1 mg per kg per day, right? That's kind of what we all learn maybe in training. And I think the low that was used in the voclosporin study was almost more like 0.3 mg per kg per day. And I would say a moderate dose of steroid would be considered at least, 0.3 to 0.5 mg per kg per day. And I think that goes along with the more recent KDIGO guidelines that came out in just several months ago.
Okay, and then we have another question from Dr. Charles Omondi, that some centers use Retux as a salvage therapy for lupus nephritis despite the data. So he's asking for a comment.
Yeah, and I'll say I think a lot of that is guided by cohort studies that showed that rituximab has seemed to be effective. Now, these were messy studies because all sorts of therapies were used. But that patients with resistant, what they described as defined in multiple different definitions of resistant LN, was that patients who received rituximab had improvement when they weren't responding to other therapies. And I will say, even though the large clinical trials were negative, there is some credence to using BLISS-LN therapy in the setting of lupus nephritis, as shown by the BLISS-LN and Obituzumab study. I think it's important that you get B-cell depletion. I think the other thing that's important to note is that rituximab, just like any B-cell therapy, takes a long time to work. And so one of the caveats and limitations of the LUNAR study was that they stopped at 52 weeks. And actually, if you looked at that patient population in LUNAR and you extended the data out to 75 weeks, there was a signal. There was also more partial responses in the rituximab treated group than in the standard of care group. So there may be some credence to using rituximab despite the negative large randomized controlled trials. I think, and even I use it on a case-by-case basis. It's not the first drug I reach for. But if you talk to Liz Lightstone in Europe, in the UK, she uses it routinely as part of her induction regimen with mycophenolate in a predominantly European Caucasian population and tends to have good outcomes. So I think it's one of those therapies that are in our toolkit, so to speak. It certainly is not standard of care overall. But if you're struggling, if you have patients that are not responding to the therapy that you're giving, or if you're really worried about adherence to oral therapy, then I think rituximab is an option that's worth considering, at least until we have new data suggesting other drugs are potentially better. And then, of course, now you can think about Benlysta as well, though it doesn't really deplete B cells. It kind of paralyzes their action a little bit. I hope that answers your question.
Thank you.
I think I have a question, and I hope it's okay to announce about what is the alternative to immunosuppression of mycophenolate if diarrhea is not well tolerated in lupus patients or renal transplant. And I think, I don't know what access is present, but mycophenolate sodium, so Myfortic, could be an option to try. But if that's also not tolerated or too expensive or not available, I think the general approach would be Imuran or azathioprine as an alternative. And certainly, at least in the European data, it suggested that for maintenance therapy, MMF and azathioprine were similar. It's certainly our alternative approach if people don't tolerate mycophenolate. And then, again, that's where potentially where something like a rituximab could come into play as well. I don't know about renal transplant, but certainly for a lupus patient.
Thank you, Dr. Samir. Professor Bhima has raised his hand. Professor Bhima, welcome.
Thanks a lot, Samir, for that excellent presentation. And I really, impressed by all the data that you presented. I'm going to talk from the pediatric side because, of course, I'm a pediatrician, right? So I don't expect you to answer the question exactly the way I would expect a pediatrician to answer it. But, lupus in children is much more aggressive than what you see in the adult population. And so, we are forced to use much higher doses, both of steroids, MMF, per kilo per meter squared, or whatever way that we are measuring the drugs, and to attain remission. And what we find that, when we use these agents, and if we stick to the dosages that are prescribed by the adults, we don't actually attain remission as good as what we would. For instance, if we look at methylprednisolone, I mean, induction therapy, most will use maximum of about 500. We have to use 30 per kg, sometime a maximum a gram, in order to try and get the patient into remission. So, lupus in children is much more aggressive. Now, with the use of these agents, etc., the biggest problem we run into with cyclophosphamide, of course, in our adolescent patients, especially males, is sterility, etc. What's your take on that? I mean, what do you think?
So just a couple comments to that excellent point. Agree 100%. So my colleague in my clinic is the head of rheumatology at Children's Hospital, and so we work together in our multidisciplinary clinic. She's a rheumatologist, and we talk about this all the time. Lupus, the phenotype of lupus is very aggressive in pediatric population. It's different, and one of the biggest misses, so to speak, or issues I have, and this is me, in talking to other pediatricians who focus on lupus, is they don't study lupus in kids enough. Like, we don't do enough clinical trials in the pediatric population. We need to do that. Because you're right, 100%. that the treatment for an adult may not be the same as a child with or adolescent with lupus nephritis. Completely agree. And high doses of steroids are needed oftentimes, with associated with tremendous side effects, right? AVN, avascular necrosis, etc.
Yes.
High doses of cyclophosphamide, sterility is an issue. We give testosterone injections for that for our males. There's not great data on that, frankly, but there's some data to suggest that that would be helpful. And of course, banking, sperm banking. And then for females, we use Lupron when we can get our hands on it. It's very expensive.
Yes.
And preservation, if possible, is also a consideration. But those are for adults too. You know, in the setting of pediatrics, and I don't know, I'm not a pediatrician, but I imagine when these patients are on flare, they're so sick and require so much therapy sometimes that, you know, having kids may not even be at the front of the minds, right? Depending on the age of the child.
Exactly.
And so, yeah, and so I think that is a real hole in the data, and it's something that there's bodies that are looking at this and saying we need to study pediatric lupus because it's a different beast.
Yeah, the problem is that, you know, the number of cases that we have in pediatrics compared to adults is very low. So, you know, to get the number of patients, a requisite number of patients to run a full, you know, randomized trial is very, very difficult. But just one other point, if I may please ask, what about ancillary therapy, like use of ACE inhibitors, simvastatin for lowering cholesterol agents, etc.?
Yeah,
we
so
put
I think
quite a bit of emphasis on that as well, because many of our patients don't go into full remission. So what's your take on that?
Yeah, certainly for the adult population. So two things, right? So not always with lupus nephritis patients do they have high blood pressure, so you have to be careful. Young females, they tend not to have, you know, high blood pressure, but I certainly favor ACE-ARBs if we can do it. And you certainly want to optimize it. Statins, especially if they're proteinuric, lipidemic, you know, all these patients are at high risk for early cardiovascular disease. So this is part of the concoction. And one other therapy I want to highlight that's super important, and I didn't spend a lot of time in talking about it or any time, is hydroxychloroquine. Or chloroquine.
That was my next question. Sorry.
Yeah. There's plenty of data that chloroquines help prevent flare, improve outcomes. They're obviously important for lupus and pregnancy. And so all patients, unless contraindicated, should be on a chloroquine for sure. So I think these therapies are important. And then, of course, assessing the risk for clot is also something that needs to be done, whether it's baby aspirin or anticoagulation, because a good percentage of our patients will have antiphospholipid syndrome.
Yeah, I must say, in pediatrics, we hardly see many patients, except for the adolescent patients. We hardly see antiphospholipid syndrome in our population. I don't know what it is.
That's good. That's good.
We have a predominantly Black African population.
Yeah.
So we don't routinely give anticoagulants, but we definitely look for antiphospholipid. You understand? Right?
Yeah. So I think looking for it's important. Yeah, looking for it's important. Whether it's just so you can catch it if you see it, and you know those antibodies are so fickle. They're hard to get, and so it's you know, sometimes it's the antibodies are negative, but you get this classic presentation of recurrent strokes or persistent headaches uncontrolled, like the memory loss, and or you get this vascular injury on biopsy that's suggestive of, you know, zonal scarring, and you think, oh, maybe there's some hypercoagulability going on, but it's a very challenging diagnosis to make in a lot of cases.
But I must say, because hydroxychloroquine is cheap, you know, we kind of use it as routine, part of our routine.
Absolutely. Treatment. And it has some anticoagulation properties to it. So we use it routinely as well. Absolutely.
Yeah. Absolutely. No, thanks. Okay. Thanks a lot. Sorry to take up time.
No worries. Great question.
Yes.
Thank you, Professor Bhima. So going back to the chat box, and we have a question from Dr. Ann Sala that actually voices the concern that we have in this part of the world that in many centers which cannot perform a kidney biopsy, what markers can we rely on for the diagnosis of lupus nephritis?
And I think we're limited on our markers right now, at least what's available clinically, right? I would suggest that this goes back to our, you know, old school teaching of urine microscopy, urine protein creatinine ratio complement and trends in complement. So you see a decline in complement, maybe it's not so severe, or maybe it's not abnormally low, but the trend is downward. You see proteinuria, you see urine microscopy or urine sediment is concerning. Even at low levels of proteinuria, if I see concerns with active urine sediment because there is data to suggest that even low levels of proteinuria, if you have active urine sediment, red blood cell cast, dysmorphic red blood cells, most of those patients will end up having a proliferative form of lupus nephritis. So, that's the best markers that we have right now. Unfortunately, we don't have better ones. Double-stranded DNA is not so reliable. Anti-C1q, as I mentioned, is not readily available. And I don't know how valuable it is, frankly, in the setting of monitoring disease activity, number one, or even in establishing diagnosis. The hope would be something like soluble urine CD163, if it can be validated in a large trial, or some of the stuff, the rail markers that are being done down the street from me at Cincinnati Children's Hospital, where they're looking at composite biomarkers such as LFAB and GAL, that those may be validated and may come to clinical practice soon, so that we can maybe have a urine biomarker or composite urine biomarkers to kind of help us establish a diagnosis, or at least that correlate with disease activity in LN that we can use if biopsies are not available. But right now, we're still kind of with the general approach of complement, double-strand DNA is the best utility you can use it, proteinuria level, and urine sediment, as well as kidney function, of course, unfortunately.
I do hope you have 12 more minutes for us to take more. So,
yeah, no, I'm happy to. Yeah, I'm happy to. Yeah.
So how do we manage flares in lupus nephritis patients?
Yeah, so you're talking about relapses, right? So yeah, I want to make sure. First flare is one thing. We talk about standard of care, right? So cyclophosphamide, mycophenolate. Right now, the management of a flare or a relapse of disease is not too different than the original flare, right? It's either going back, like a lot of it comes down to is the patient on any therapy right now? And if they are, what are they on? Are they flaring through it? And if they are, then maybe that's not a good medicine to stay on, but maybe it's mycophenolate, something like that, and you need to switch to cyclophosphamide, or maybe they're on minimal dose of therapy, just hydroxychloroquine or something like that, and they flare. And in that scenario, you're almost starting over, right? So you go back to mycophenolate, steroids. Now you can use a calcineurin inhibitor, maybe multi-target therapy, or go back to cyclophosphamide, although you want to be careful with how much total dose cyclophosphamide someone gets, because the risk of cyclophosphamide, bladder toxicity, lymphoma, leukemia, bladder cancer is based on cumulative dosing of the disease, fertility issues, of course, too. But it's basically going back to square one and starting again. There is some interesting transcriptomic data that looked at flares versus relapses and showed that, at least immunologically, they may have some differences. But at this point in time, right now, the management of a flare or relapse is pretty similar to what our standard approach is, as outlined by the guidelines, whether it's cyclophosphamide or mycophenolate, and then potentially adding one of these new therapies, such as calcineurin inhibitor or Benlysta. Okay.
Thank you very much. And then there's another question asking whether ACE or ARBs should be started during an active lupus nephritis flare with a high creatinine, or should we wait till the pulsing with the steroids is done?
Yeah, so I think that's a good question. I think timing matters. I don't think there's any rush to starting an ACE or ARB unless the patient's hypertensive, right? I think especially in the setting of an acute kidney injury, where you have a high creatinine, the focus should be on anti-inflammatory therapy, getting the LN under a little bit better control, and then using the ACE or ARB down the road once you have stable function to help with blood pressure, antiproteinuric therapy, and just overall RAS blockade. So I don't think there's a rush. I think the thing is ACE ARBs, they're not going to fix the disease, right? They're supportive therapy. So I think we should think of it as that. And we should focus on, doing what we can to control the disease first. And if you can get some stability in kidney function, then that's when I would kind of think about adding the RAS blockade. Of course, if you have an out-of-control blood pressure, you got to do what you have to do, because, the likelihood is that blood pressure is being driven by RAS, aldosterone because of the kidney injury anyway. So, but I think generally speaking, I would try to get the immunotherapy on board first in that situation and think about RAS blockade down the road.
All right, and we have a question from Dr. Ben, and he's asking if you could ever get a normal serum creatinine level in patients with class 3 or class 4 lupus nephritis.
Yeah, I think that goes back to the definition of normal, right? I think I have plenty of patients that their creatinine really doesn't change in the setting of class 3 or lupus nephritis from baseline. Frankly, it looks normal. It's 0.6, 0.7 milligrams per deciliter. And then you get on treatment, you reduce the proteinuria and things like that, and it doesn't change. And so you certainly can. But I think more to the point, maybe of the question is that all of these patients are going to be left with chronic damage regardless. And whether that shows in the setting of with creatinine, maybe, creatinine like a late marker of chronic damage, really, it may or may not, but it will down the road. And so I think chronic damage accumulates early. Histologically, we see that. And that may or may not be told by the creatinine value. Maybe the level of chronicity may be associated with that. Study's not been done. But you can get back to a normal creatinine, but what does that really mean? I don't know. I would say that if you get back to a normal creatinine, that doesn't necessarily mean that you have normal kidney. And I guess that would be the best way I could put it. But in a lot of cases, if they have severe renal injury with a severe AKI, and in a good percentage of those patients, they won't return to normal. But hopefully they'll get back to close to normal, or baseline, I should say.
Great, and we have 3 questions from Dr. John Gumbi, and the first one of these 3 is that, is there a way to prevent development of lupus nephritis in a systemic lupus patient who is yet to develop lupus nephritis?
Yeah, so 1, we don't have good prediction tools on who's going to get in, who's not. That's 1. 2, I think close follow-up is important. And of course, a lot of this is going to be with the rheumatologist, right? We're not necessarily involved in those cases. Routine evaluation of the urine is helpful, and not letting SLE, non-renal SLE, go unchecked. So treating that with immunosuppressive therapy to control the disease is important. So don't let someone ride with a low complement active, SLE parameters, whether it's rash, joint pain, whatever, with just hydroxychloroquine for too long. I think, there's no good defined answer for this, but because I think a lot of times when we see the patient, it's too late. But if you're going to prevent, I think hydroxychloroquine, go back to hydroxychloroquine, and go back to effectively controlling the lupus in the first place. So early disease recognition of lupus, treatment of lupus, and certainly hydroxychloroquine would be, and then frequent checks. And, our rheumatology colleagues check urinalysis with every visit. I think that's along the lines of what's generally recommended, and then not sitting on that for too long if you see any abnormalities.
We actually have the same question from about 3 people, and they're asking on the post-transplant management of lupus nephritis.
Oh, okay. That's the one thing that's interesting because, LN itself does not recur very often in the setting of transplant. And I think part of that might be, it's not 100% clear why. SLE certainly can come back, but it doesn't really come back all that aggressively. And maybe part of that is because of the therapies we use for transplant. Again, mycophenolate, cyclosporin, tacrolimus. And then perhaps it's due to the induction therapy that's used post-transplant. But we don't see a lot of active lupus nephritis post-transplant. That said, if it does to come back, 2 things to think about. 1, the timing of transplant. I think it's important that before transplant, patients' lupus and lupus nephritis should be as controlled as possible, and for several months before considering transplant. Then that'll mitigate relapse. 2, in patients who do relapse, and if they're on, routine transplant therapy, considerations need to be given to additional therapies like cyclophosphamide, perhaps, or even B-cell depleting therapies like rituximab, in addition to the mycophenolate calcineurin inhibitor. So there aren't great studies that look at post-transplant relapse of lupus nephritis, I think partially because it's so rare. But in the cases that we have seen, that's kind of what we go to. And maybe these new therapies, not necessarily the calcineurin inhibitor, but maybe the B-cell therapies may be something to be considered in these patients as well.
I saw Dr. Lloyd had unmuted for a second. Dr. Lloyd, do you have a question?
No, actually, no. The thing is there this biopsy has been a controversy, Samir, I think from quite some time. Some people say no biopsy, some people, but and from your presentation now, I think, is there a role for more aggressive protocol biopsies, for histological activity?
So I want to be clear on that, right? So, I don't know that protocol biopsies are, it may be something that we need to think about in the future, but I'd like to see more data, right? We have two small studies that looked at this. We need longer follow-up. I think we need more data. For my intents and purposes, I only do repeat biopsies for cause. okay? And my for cause is patients who have the best possible remission I can get with my current therapy, but have persistent proteinuria. And I'm not sure if they have active disease or chronic damage, and I need more information to decide on what to do with my immunosuppression. Do I intensify? Do I switch? Stay the course? Or do I reduce? Because it's all chronic damage. In patients who have complete clinical response, I still think, and the data suggests this, that the best metric we have is proteinuria. And if proteinuria is controlled and they have complete clinical response, while I think the data are interesting and something that should be considered in a patient you're thinking about taking off therapy, and that is something that we're doing a little bit more here now. I think it would be better to have larger clinical trials or larger trials showing that this is indeed what we should be doing, because it is invasive. It's not readily available. They have complications associated with biopsies. Now, I do my own biopsies here at OSU. I'm the one who does it for our group, and we are doing them more, but that's not the case everywhere. And the quality of sample matters as well, and access to a nephropathologist who can give you a good read. All of those variables are important. And so I think that's an evolving conversation. I think the conversation of whether to do a biopsy or not is frankly a silly one right now, like at baseline, if it's available. If it's available, I think you should do it. Because at least outside of class designation, you glean a lot of information from the biopsy itself, chronicity, activity. Those things influence what you're going to do with your treatment. And trust me, we've had these conversations and debate with Fernando Fervenza at Mayo a lot. And again, I think also populations are different, right? So it depends on what kind of population you're seeing. I can only tell you the number of times I've diagnosed multiple different processes going on in a lupus nephritis case, including TMA, podocytopathy, et cetera. And you don't want to miss that, because you're going to lose nephron fast. So if you can, I think it's feasible to do a baseline biopsy. I think there's a real question on whether to do a repeat biopsy. Our rheumatologist will tell us always yes. I think as a field in nephrology, we've been pretty hesitant. And part of that is resources. Part of that is concern for risk. Maybe some of the concern for risk is a little overblown based on the data that's out there. But also access to dedicated kidney pathologists who know how to read these biopsies. All of those things matter and are factors for sure.
Thank you so much. Thank you.
Dr. Samir, we'll sneak in one last question before we let you.
Sure.
What is the target tacrolimus trough level in multi-targeted therapy?
Yeah, so and I actually presented this a couple of years at ASN, and so I looked at all the studies that looked at tacrolimus, and there was no standardized, but I think in general 4 to 6 was the level that was targeted. If you look at the Moroni paper, and even in this Asian study, 4 to 6, I would maybe even say 5 to 6 in that range is kind of the range trough level that people go for in the setting of lupus nephritis. So maybe a little bit lower than what you might consider for something like kidney transplant.
We do have more questions coming in. However, I'm hoping you would be happy to take them on email in case we circulated it.
Yeah, actually, would that be okay? I'm happy to answer all questions. Absolutely. If there's a way to email these to me, I'd be happy to respond. Yeah. And I'm also happy to share the slides. That's not a problem from my perspective either.
So we'll just and then send them over to you, and we'll send the responses back to the people who mailed it out to us.
Yeah, that'd be great. That'd be great.
A great pleasure having you here with us this evening, and your talk was absolutely wonderful. Thank you so much for taking time out to be with us.
No, thank you for having me. This was fantastic. Very much enjoyed meeting you all by Zoom, maybe one day in person. But this was really fun. I enjoyed it, and I certainly look forward to further discussions in the future. So thank you so much for having me.
Thank you.
Perfect.
Thank
Dr.
you so
Lloyd,
much,
one last comment from you, Dr. Lloyd.
Yeah, thank you, Samir. It was a wonderful session. Extremely well covered and very comprehensive with all the data and evidences. Of course, you're one of the world's top experts in the subject, and we look forward for more of these from you when time permits from your side.
Yeah, happy to. Absolutely. Thank you.
Thank you so much. It's a lot of learning, and see the questions that came. And we maxed out, actually. We have 100 participants normally that are supposed to attend, and it was 100 all through the.
That's awesome. That's cool. And I very much enjoyed it. And like I said, I'm very happy to answer all the questions, and always happy to come back. This was really cool to do, and absolutely. And best of luck to all of you. Enjoy the holidays coming up, and look forward to further interactions in the future. For sure.
Yeah.
All right.
Thank you so much.
Thanks a lot.
Thank you so much.
Thank you.
Appreciate it.
Bye.
Take care. Bye-bye.
Bye.